Thank you to the organizers for inviting me to contribute to the conference at Higher School of Economics in Moscow, Russian Federation. It's an immense privilege, especially as I had a wonderful opportunity to work in the Russian Federation for many years and being involved in health system reforms. My presentation is going to focus on initially health systems, the challenges that health systems face, and secondly look at some solutions, specifically looking at a transition towards a primary healthcare-led health system. First of all, what are the health system challenges? There are 5 major challenges health systems face globally, and Russian Federation is not alone. First of all, there's higher demand due to aging, the rising burden of multimorbidity and disability. The second challenge is low productivity and inefficiency and poor quality. The third challenge is widening inequalities. The fourth challenge is rising citizen expectations. And the fifth, fiscal constraints, as many countries face economic pressures and pressures on their public sector budgets to increase investment in healthcare. Therefore, we have to make judicious use of the resources that we have. And primary healthcare offers the possibilities to get more out of health systems. But let me expand on the challenges, specifically on the poor level of quality, inefficiency, against the background of rising morbidity. If you look at hypertension, which is one of the commonest chronic illnesses around the world, certainly in upper middle income and higher income countries. So in Canada, which has very good primary healthcare system, awareness levels are 83%, 79% of those with hypertension are treated, and 65% are controlled. If we look at England, the levels fall to 66, 54, and 28. In the Russian Federation, levels are even lower, with 59% of those with hypertension being aware, 45% treated, but only 7%, according to the World Bank study in 2013, actually controlled. So there's a huge opportunity loss in terms of preventable morbidity and mortality in relation to hypertension. But hypertension is not the only problem. Many countries around the world, including Russian Federation, face the challenge of multimorbidity, having more than one chronic illness. So if you look at this, is a study we published in PLOS. And if we look at age groups and prevalence of multimorbidity, so those having more than one chronic illness, in those aged 60 to 69 years, in Russian Federation, the level is 50%. And those aged 70 or more, the level rises to 65, more than 65%, higher than other upper middle income countries. And implications of this is that there's huge burden on the health system because the utilization of both outpatients and inpatients increase. So those patients with 2 chronic conditions compared to 1 or no, there is 1.5 times greater odds of being hospitalized. The same figure applies to outpatient utilization. So higher the multimorbidity, the greater the utilization. And there's evidence from other countries to show similar results. Clearly, health systems are not able to cope with the rising demand on the system due to rising disability and multimorbidity. So what's the solution? Well, necessarily the solution has to be primary health care, because one cannot treat or manage risk factors for chronic illness as well as the morbidities they bring in hospital setting. So one has to establish robust systems in the community, also in primary healthcare setting, to manage these conditions effectively. But what is the evidence for primary healthcare? Well, evidence is fairly extensive. And this is a review I did for the World Health Organization, WHO European Regional Office, that looked at evidence for health systems that have a primary healthcare orientation compared to those that have a hospital orientation. And the evidence suggests that increased primary healthcare availability leads to higher patient satisfaction, reduced aggregate spending on healthcare, greater pro-poor orientation, and enhanced equity as a result, improve access and accessibility to services. When care is shifted from specialists to family medicine specialists, family physicians, or general practitioners, there are no adverse outcomes in care quality, but costs are reduced. Similarly, as we substitute services from hospital to primary care, we have improvements in outcomes and reduced costs. So there's greater cost effectiveness. So there's a compelling case for investing in primary health care. But what does this mean in practice? It means two things. First of all, optimizing effectiveness by expanding the scope of cost-effective services provided in primary health care setting. And secondly, optimizing efficiency, delivering these services in an optimal way by integrated care and by task shifting from specialists to family physicians and from family physicians to nurses and other health professionals, especially primary health care teams. So in terms of optimizing functions, we need to transition from primary health care being a doctor-centric and basic model, which what I've called traditional primary health care, where the first contact functions, continuity, coordination, and comprehensiveness are limited, to a new primary health care model that is transformed, where the patient is at the center, so person-centered health services, with primary care playing the role of providing most of first contact services, both for acute episodes, but also for routine episodes. Comprehensive services for health promotion and prevention, with expanded diagnostic capability, and community-based health services, including hospital at home. Then improving continuity of care in primary care setting for management of chronic disease. Someone with hypertension or someone with diabetes will have these conditions for 30, 40, 50 years. So continuity is critically important. And primary health care is the domain where this can be achieved cost effectively. And of course, primary health care offers the opportunity for care across the life cycle, from cradle to grave, as is the statement in relation to the national health system in England, which has a very strong primary health care component. And the fourth important function for primary health care is coordination, coordinating the journey of the patient from community to primary care, from primary care to hospital, and back from hospital to primary care setting again. Now let's look at a couple of case studies of countries that have introduced primary health care and scaled services rapidly to achieve improved health system outcomes, reduce out-of-pocket expenditures and catastrophic spending, but also improve user satisfaction. And the two cases I will discuss briefly are Turkey and Brazil. Turkey, prior to 2003, faced major challenges. For example, there was very fragmented health system with 5 separate sources of financing with different benefits packages and very limited coverage for the poor. In financing, there was low overall spending in health, and it was highly inequitable. In terms of resource management, there was not enough doctors, nurses, and midwives. And when they were available, again, they were not appropriately distributed around the country. So there were huge inequities in resource allocation. As a result, services delivered were inequitable, mainly in urban areas. There was limited prevention services, and hospitals were often used as the first point of contact. And they faced long waiting times with low satisfaction levels from the population. If you look at coverage of the poor population, or coverage of the population, if we divide them into deciles, from the poorest to the richest, and look at the insurance coverage, we can see that the poorest, only 24% were covered. And as we move towards richer groups, the coverage increased, but huge differences between the poorest and the richest groups. Now, to address the inequities in health service delivery, health financing, and health outcomes, Turkey introduced a comprehensive health transformation program, a comprehensive strategy that increased financing, coverage, insurance coverage for the poor, as well as service delivery. And the focus of the efforts was very much on developing comprehensive primary health care. And the implementation was flexible with strategic and tactical moves to ensure one was able to implement these reforms in a manner that was fit for the context. And there was a big focus on user satisfaction with ongoing monitoring to understand what was being valued by the end users. So what happened? Following the introduction of health transformation program, health insurance coverage for the population as a whole increased, particularly for the poor. So if we look at this figure, we now see that the coverage for the poor is 85%, and for the richest group has increased to 96%, but there's increase for all the groups. But very importantly, what happened with the health transformation program is not just implementing financial coverage, the benefits were also leveled up across different insurance groups. But very importantly, primary healthcare was scaled up. So between 2005 and 2010, the whole country was covered with a scale-up of family health medicine-centered primary healthcare services, such that compared to 2000, where we see huge lack of human resources, particularly in the center, east, and the south of the country, by 2010, the whole country is covered by primary healthcare teams, with some need in the east and southeast of the country. So what's happened as a result of scaled-up primary healthcare? First of all, we see that the utilization of primary healthcare increases. Even though patients are able to access hospital services directly without any gatekeeping, we see that from compared to 2004, there's an increase in utilization of primary healthcare and a sharp increase after 2009, where we see a decline in use of hospital services. Private sector utilization remains fairly flat. If you look at the reasons for choosing primary health care, the first contact services, whereas in the early part of the reforms it was due to necessity, in latter part of the reforms it's because patients are satisfied with quality of primary health care provided. This is very important because this shows that patients are able to shift from secondary to primary health care because primary health care is able to provide high quality services. As a result of expansion of primary health care services, we see an improvement in health outcomes. For example, compared to if we look at 1993 or even 2003, if we look at under 5 mortality and infant mortality per 1,000 live births, we see a big difference between mothers who are well educated and mothers whose education is low. And if we look at urban and rural, for example, in urban compared to rural, or the richest quintile compared to poorest quintile, there are big differences. And these differences persist to 2003. But following the introduction of reforms, we see a sharp decline in under 5 mortality, but also in infant mortality. And we see a convergence. So under 5 mortality declines, infant mortality declines, but we also see a convergence and reduction in inequalities. This is few years after the scale-up of primary healthcare reforms. We also see out-of-pocket expenditures at different budget thresholds, again declining at 15%, 25%, and 40% budget thresholds. If you also look at user satisfaction, whereas in 2003, health services were, or the health system was the lowest rated public service compared to social insurance, education, legal and judiciary services, and public security and order. By 2011, it continued to increase, and it was one of the services with which the population had high satisfaction. This helped the incumbent government to be re-elected repeatedly. Let's have a look at Brazil. Brazil is, again, a huge country, and Brazil introduced multifaceted reforms. This is captured in a paper we published in The Lancet that looked at universal health coverage in Latin America. Brazil introduced universal health coverage based on primary health care and family medicine services, with outreach to communities and to households, and with a combination of public health interventions to manage risk and social determinants of health. And there was a huge effort throughout the years to strengthen primary health care and improve supply of family physicians, family health teams as part of the family health strategy. And we can see here that compared to 1999, where there was very poor coverage throughout the country, in 2002 we see increase, but by 2012 most of the country is covered by family health teams. And what happens as a result of this? Well, health outcomes improve, and I just want to show you infant mortality rate per 1,000 live births as an illustrative case. Whereas Brazil had one of the worst rates in 1990s, before the scale-up of family health services, we see sharp reductions and convergence with other countries in Latin America. We also see, very importantly, for countries such as Russia that are undergoing or that have undergone rapid demographic and epidemiological transition with rising chronic illness and multimorbidity, following the introduction of family health strategy in Brazil, we see, and this is a paper we published recently in Health Affairs in January 2017, we see large reductions in amenable mortality, i.e. mortality that, premature mortality that can be prevented if the health system is functioning well. And we see greater reduction in areas where family health strategy is introduced compared to other areas where it was not introduced as intensively. We also find that in the presence of good governance, amenable mortality declines even further. So there's very good evidence generally to show that primary health care is more equitable, much more cost effective. It provides the platform for a patient-centered universal health coverage, but very importantly, it is the platform for addressing problems of today and problems of the future, namely chronic illness, multimorbidity, and disability that countries like Russia faces. But Almaty Declaration was in 1978, was in then Soviet Union, and the Soviet Union went on to produce very strong primary healthcare services. There's an opportunity now, given the big health system challenges Russia faces, to relive the spirit of Almaty Declaration, to introduce highly innovative primary healthcare services in the Russian context to address the growing burden of chronic disease, multimorbidity, and disability. Thank you very much for your attention.